Research Association.
So thank you being here in your nice country in Singapore, and that I can talk about radius fracture volar strategies in treatment for volar radius fractures. Some biomechanical considerations. There is a tendency of the carpus to glide ulnarly and volarly, and against this tendency works dorsal, the so-called dorsal V ligament, and volar, the two volar ligaments, which hold the carpus in position. And these two ligaments together form a volar to dorsal sling and hold, as I said, the carpus in position. So depending on the direction of acting forces, we get radial-sided fracture or ulnar-sided fractures. And you see here the wrist position on the motorcycle handlebar, and on an accident you see here different positions of the lunate. And you can see here again, it depends. If the forces act more dorsally or volarly or even central, you get dorsal fractures, volar fractures, or central depressions. And based on the papers, and most of you were missing the first lecture of break pain, on the concept of Brink and Wrigley, which is the first CT-based concept, and Craig Penn, who was talking about the osteoligamentous concept, that ligamentous insertions, so to say, reinforce the bone, and the fracture lines go between that ligamentous insertions, and they stay intact at every fracture, almost already in all fractures. We presented that biomechanical consideration on a CT-based treatment, now treatment-oriented classification, and from that classification I will point out the volar-sided key fragments. So, volar key corner fragments form, as I said before, an osteoligamentous unit, and it's the insertion point of really important ligaments from the ulno-lunate and ulno-triquetral ligament, and also the volar radio-ulnar ligament. And then when this fracture type tends to dislocate to the volar side, as you can see it here, because of the ligaments are like a belly around it on this ligament, and they dislocate with the fragment. So volar key type fragments can be big fragments and can be small fragments, and the smaller the more dangerous they are, because they are underestimated and you can see them not really in plain X-rays. The grade of volar instability depends on the fracture position and size. You see here left the ulnar key corner and right the radio-ulnar key fragment. The whole radial volar lip is broken. And so it depends. The key fragment dislocates with the carpus to the volar side. If you have only a volar ligament, you have a rotatory dislocation. And if you have the whole amount of volar lip, you have a parallel complete dislocation. And also the small fragments, they are indicators for different types of instability. You see here on the left, a volar-directed forces, it produces a volar shear fragment. On the right side, you see a dorsal-directed force, and it produces a volar tear-out fragment and dorsal a shear fragment. And you can see from the type of fragments which instability you have to await. And here you see the mechanisms of dorsal dislocation, and during reduction, the volar fragments turns around 180 degrees. So even if you have a dorsal dislocation, on the left side you have a dorsal key fragment, on the right side you have a volar key fragment, because you see that the lunate is still adapted on the volar fragment, and treatment is quite another on the left and on the right side. So what access do we use? We always use a radial-sided access, never go in ulnar from the flexor carpi ulnaris, and we release the tendon sheet of the flexor carpi radialis on the roof and top to release the tendon and get more space. If you take an ulnar-sided incision from the median nerve, you get severe scarring sometimes of the median nerve and can cause chronic pain or CRPS syndrome. So my first case, you see here a plain X-ray. Do you see something? You will say, no. And you see, look at the ulnar corner. That's really the same case. And if you make a CT scan, you see that volar key fragment, which is very important. And don't try these fractures even when they are in correct position in a cast, because you will fail. They went to the volar direction in the next week or in the next 2 weeks, and then it gets difficult. Here another case. You see here the surgeon said it's clear. We have a big volar fragment, no CT was made, and that's also a message. Always make CT scans in intra-articular fractures. And I ask you, is that well done? It looks, yes, but you see here 1 week later, the carpus is migrating. He did not catch the key fragment. You see here on the ulnar side, it is a radial-oriented plate, and that cannot catch the key fragment. The carpus is migrating on the volar side. Here is a overseen key fragment, and what is a solution to catch his fragment? This ulnar key fragment you can only catch with adequate plates, and that are like this FPL plate. We will hear later on about this plate. That catches the fragment very good, and here the result. Here, the small volar rim fragment, as I said before, are a problem to catch them. And you see here the CT scan, and you see here the CT scan and the reduction on the right side, and the opening reduction with K-wires and with this bank of hook plates. Under the X-ray intensifier, if you have repaired with a plate or with a hook plate, you have always to prove the volar translation. And if you have still a volar translation, if you have fixed it, we do a K-wire for 6 weeks in the cast to stabilize the carpus in its position. And you see here the K-wire, cast 6 weeks. Immediately, if you reduce the cast, you have to reduce the K-wire. And here you see the reduced K-wire, and here after 3 months, and a really good function. You have heard it already, makes sense sometimes to do it also arthroscopically assisted in horizontal traction. You see here the tower of Borelli. If you have a combination of fracture types, like in this type, you have one metaphyseal fragment, 2 a very distal rim fragment, 3 radial styloid. You can combine plates and hooks. Here you see a hook plate failure. The hook is mounted at the wrong position. You see here on the right side the missed volar fragment. And why is that so? Because he did a very small incision. He had not the correct overview over the whole volar rim, and he went in very wide ulnarly, and he had some troubles. And you see here, we did a revision operation. We put it out the hook plate and mounted a good ulnar-sided plate as a buttress on the ulnar side, which can catch that fragment. And here the result. So, what are our goals for fracture-specific treatment? We want a plate which can be the jack of all trades. And the question is that plate existing? I tell you, no. Analyze the fracture in 3 planes. You then you will know where is the fracture, what size has the fracture, and that's the best way to analyze a fracture. From the axial view, go through the other planes. You have to merge them in your brain in a three-dimensional understanding, and then you know what you have to deal with. Yes, you see here different volar key types. You see here a small rim fragment, a big rim fragment, a metaphysical ulnar volar fragment, a radio-ulnar volar fragment, and you see here different types of plates which can catch these fragments best. Here you see the X-rays, and you see here ulnar-oriented plates are the best for ulnar-oriented fragments. Radial-oriented plates are not so good for that type, and special ulnar plates I've already shown you. So the conclusion is a CT scan for identifying which specific volar key type you have, always operatively, anatomic reduction, maybe arthroscopically assisted, specific device for specific type of key type. If after fixation the carpus is not stable, transfix it for 6 weeks and reduce it after cast removal. Thank you.